Welcome to Chapter 9, covering the neck and trunk. So the neck and trunk have to support a lot of weight. The weight of the head, the shoulder girdle, our upper extremities, and the trunk is transmitted through the vertebral column to the pelvis, where it's then distributed to the lower extremities to support the weight on the ground. And so we have to consider the function of those muscles in maintaining upright postures and the weight that they need to support. Our vertebral column is our bony protection of the spinal cord. It also provides the weight-bearing support of the trunk. It is separated into 5 different regions. So our cervical region has 7 vertebrae. Our thoracic region has 12 vertebrae. Our lumbar region has 5 vertebrae. Our sacral region is 5 fused vertebrae, and our coccyx is 3 fused vertebrae. Those sections break down into different curves, and the curves of our spinal column help contribute to our posture. And so when we have abnormalities of those curves, we have abnormal posture and vice versa. Our cervical and lumbar regions are convex anteriorly, and they are lordotic curves. So when we refer to excessive curvature in those curves, we call that lordosis. Our thoracic and sacral regions are concave anteriorly. Those are our kyphotic curves. And when we have excessive curvature in those curves, we call that kyphosis. This picture is important for you to know and understand for the direction of the curves, and it'll be important as we get into posture, but for your exam purposes as well. Now, if we look at motions of the vertebral column, motions of individual vertebrae are going to be restricted by their orientation and bony prominences or bony articulations, but the spinal column as a total, or a vertebral column as a total, is triaxial. So we look for motion in all 3 planes of motion. And this is going to constitute motions of the neck and trunk. Both are going to be triaxial. So if we look at our neck motions up top, we have flexion, moving the chin towards the chest, and extension, moving the head back so that the nose points up towards the sky. Again, your textbook refers to extension as the return from a flexed position to neutral, so hyperextension is going to be that looking back up towards the sky. The trunk, same thing, so bending forward is going to be trunk flexion, returning back to that neutral spine is going to be trunk extension, and then bending backwards at the trunk is going to be trunk extension. For lateral bending or lateral flexion at the neck, if I take my right ear towards my right shoulder, I have right lateral flexion. If I take my left ear towards my left shoulder, I have left lateral flexion. For the trunk, if I take my right hand and slide it down my right leg, I have right lateral flexion of the trunk. If I take my left hand and slide it down my left leg in a standing position, I have left lateral flexion of the trunk. For rotation, turning to look over my right shoulder is going to be right cervical rotation. Turning to look over my left shoulder is going to be left cervical rotation. Same thing for the trunk. If I take my shoulders and I turn them towards my right while maintaining my hips in the same position, I'm going to have right trunk rotation. If I take my shoulders and turn them towards the left while maintaining my hips in the same position, I have left trunk rotation. Flexion and extension occur within the sagittal plane about a frontal axis. Lateral bending or lateral flexion occurs within the frontal plane about a sagittal axis. And rotation occurs within the horizontal plane about a vertical axis. Now, we talked about how at specific vertebral levels we might have limitations to motion, but the trunk as a whole operates as a triaxial, or having triaxial movement. 2 of those exceptions that we're going to talk about for limitations of the trunk are going to be our adleno-occipital joint and our adleno-axial joint. So our adleno-occipital joint is our C1 and our occiput, where those 2 articulate. So where our skull articulates with the first vertebra, and we see flexion and extension, or we get the nodding of a head yes. And there's some slight lateral bending, but we're looking at motion of flexion and extension primarily at the adleno-occipital joint. Contrasting that with the adleno-axial joint, which is going to be the articulation of C1 with C2, so our top 2 vertebrae articulating with each other, this is going to be a rotation motion, or the shaking the head no. And we'll take a look at the picture later, how C1 and C2 articulate and why we have a rotation motion at C2. But it's going to be important for you to be able to differentiate between what motion happens at the adleno-occipital joint for yes and the adleno-axial joint no. Because these 2 joints move a little bit specially because of their anatomical makeup, we have a little bit different motion occurring at them compared to the rest of the cervical spine when we're looking at axial motions. So when we talk about axial extension, that's going to be our cervical retraction, or what we will in therapy call chin tucks. So that's when you pull your chin in, not bringing the chin down towards the chest, but you're pulling the chin in like you're trying to give yourself a double chin. And that occurs when we see C1 flex, but then we have extension at C2 through C7. Contrast that with axial flexion, so that's our cervical protraction, that forward head posture that a lot of us develop as we work at the computers. That's going to occur when C1 extends, but then C2 and C7 flex. So I would encourage you to go ahead and palpate your upper cervical spine versus your lower cervical spine and try for cervical retraction versus cervical protraction and see if you can feel the differences in how your upper spine moves compared to your lower spine and vice versa, and see how they are inverted for those axial motions. There are several differences between our different levels of vertebra and their structure and shape and orientation. We're going to talk about the orientation of the articulating facets here. So our cervical spine is oriented with our facet joints between the frontal plane and the transverse plane, and so this allows for motion to happen in all three planes and axes in the cervical spine. Our thoracic spine has the facet joints oriented within the frontal plane, and motion at the thoracic spine is limited by the ribs, because remember that our ribs articulate with our thoracic vertebra. Because of the orientation of those facet joints and limitation of the motion of the ribs, we see lateral bending that happens through the thoracic spine. Our lumbar spine has our facet joints oriented within the sagittal plane, so this allows for flexion and extension with very minimal lateral bending. And if you need to, go ahead and play with your hands as far as trying to mimic the orientation of each of these vertebral levels so that you can understand why each motion can happen at each segment. Our ribs articulate with the body and transverse processes of the vertebra of the thoracic spine, and they articulate anteriorly with the sternum via the chondrosternal joints. We see elevation and depression of the ribs, and there's a slight flaring of individual ribs during inhalation and exhalation. Our sternum, which kind of provides an anterior closure for the cage made up by our ribs, has minimal movement between the manubrium and the body and the xiphoid process. They're pretty well fused together, so even though there's three sections of our sternum, there's very limited to no movement happening between them. There is, maybe slight motion as the ribs move in order to promote appropriate articulation, but the chondrocostal joints allow for flexibility because the cartilage that they are made of is more flexible than the bone. And speaking of bones, let's talk about the bones of the skull. So we have a lateral view and an inferior view here. Let's start with our lateral view. The bones of the skull are nicely named in accordance with the lobes of the brain. And so if you can remember where the lobes of the brain are placed, that can help you with understanding the bones of the skull. So we have our frontal bone that is located over top of our frontal lobe. Just posterior to that is our parietal bone, and posterior to that is our occipital bone. In between those, but more inferior, we find our temporal bone. Just anterior to our temporal bone, and it sits a little bit more recessed, is going to be our sphenoid bone. And that is where you can palpate kind of over your temple, and that's part of why you have the depression of your temple, is because just anterior to your temporal bone, it articulates with your sphenoid bone, which is a more interior bone of the skull, and so is slightly depressed compared to those external major bones of the skull. Your zygomatic arch is going to make up your cheekbone. Your maxilla is going to be the bone that makes up your upper jaw, and your mandible is going to be the bone that makes up your lower jaw. Your external auditory meatus is your ear hole, and the mastoid process is the bony prominence that can be palpated just posterior to your ear. If we look from the inferior, we can see the occipital bone in the posterior aspect. The foramen magnum is where the spinal cord exits the skull as it transitions from the brainstem into the spinal cord. We can see our temporal bone as well there, and the basilar area of our occipital bone. Protruding from our occipital bone are our occipital condyles, and these are the articulations for our atlanto-occipital joint. This should be somewhat familiar to you guys, but the bony landmarks of a typical vertebra. So if we look at our most anterior portion, that's where we see the vertebral body. Moving more posterior from there, we have our pedicles on each side, which start our neural arch as it meets the transverse process. So our transverse process are our protuberances out laterally from each side of the vertebra. Those then come back around in the lamina to meet at the spinous process. Our spinous processes are going to be the most posterior aspect of our vertebra. And remember that that whole portion makes up our neural arch. We also have our vertebral foramen that is made up by the gap between our neural arch and our vertebral body, where our spinal cord travels. You can also see the facet joints in this picture, where we have the superior articular process that would articulate with the inferior articular process of another vertebra above it. So the superior articular process articulates with the vertebra above it, and the inferior articular process articulates with the vertebra below it. Remember, these create our facet joints, and that articulation then creates our intervertebral foramen, which I believe we'll see in another picture here. So if we're comparing the vertebra, we can see that the vertebral body gets bigger as we descend down in the vertebral column. So our cervical vertebra have a smaller vertebral body than our thoracic vertebra, which is even smaller than our lumbar vertebra. We can also look at the orientation of our facet joints here. So looking at our cervical vertebra, we have that orientation between the frontal and transverse planes. If we look at our thoracic vertebra, we can see that frontal plane orientation. And then if we look at our lumbar vertebra, which I think it's a little bit easier to see, but it's not labeled on the picture from the superior view, but we can see our sagittal plane facet. So facet joints are our articulations between vertebral levels, if that hasn't been made clear yet. And we need to understand that facet joints are formed by the superior articular surface of the inferior vertebra and the inferior articular surface of the superior vertebra. So the bottom part of the top vertebra has to meet the top part of the bottom vertebra. And if you break it down into those words, I think it makes a little bit clearer sense. But if you're struggling to understand this, make sure that you take a look at a skeleton. Now, that articulation of the superior facet of the inferior vertebra with the inferior facet of the superior vertebra creates our intervertebral foramen, where our spinal nerve roots exit from. So we talked about those special articulations. We're going to elaborate on them a little bit more here. But the first and second cervical vertebra also have special names. So our first vertebra is going to be referred to as the atlas, and our second vertebra is going to be referred to as the axis. And that helps you understand, at least for the axis, why we get rotation or the shaking of the head no in that articulation between C1 and C2. C1 is more ring-shaped with no real body or spinous process. We can see we have articulations here for those large occipital protuberances of the skull to sit on. And then the large ring here that makes up that limited vertebral body is separated into two parts because of the transverse ligament. And we can see that transverse ligament here wraps in front, and that helps hold the dens in place. So that articulation, if we look over to the right, the dens is that circular part that sticks up from C2, and that sticks into the ring of C1, and it is held in place by the transverse ligament. Now, if we look at C2, it has no body, but it does have a spinous process, and the dens articulates with C1 to produce rotation. So if you can remember that C2 is the axis because it has the part that sticks up to spin around within that ring shape of C1, that can make these two a little bit easier to remember what happens. Because our ribs articulate with our thoracic spine, we have to have articulation points for those ribs. And so with the thoracic spine, we have three costal facets. Things associated with the ribs typically have costal in the name. So that's why our chondrocostal joints are chondro for cartilage and costal for rib. And so that's how we know where those joints are. Well, our costal facets are our rib articulations with the vertebral body and transverse processes. So we have 3 costal facets for each rib, one on the transverse process of the rib on the side that it is on, one on the vertebral body above, and one on the vertebral body below the rib. So our ribs articulate with our costal facets on the posterior, but on the anterior we have our chondrocostal joints. And the way that our ribs articulate on the anterior aspect defines what type of rib they are. So ribs 1 through 7 are classified as true ribs because they attach directly to the sternum. Ribs 8 through 10 are false ribs because they have that costal cartilage that combines together, so they don't have their own specific attachment to the sternum. And then ribs 11 and 12 are floating ribs because they are floating. They don't have an anterior attachment point. And this picture just helps to connect those articulations to see how the ribs come together to form a circle around the body and protect the lungs and heart. In between each vertebral level, we have vertebral discs, and those help to provide for shock absorption and allow for better motion with the awkward bony articulations of the vertebra. But each vertebral disc is divided into 2 parts. So we have the nucleus pulposus, and that's the gooey part of the disc that's in the middle, and it's primarily made of water and is described as that like gelatinous material. And then the annulus fibrosus is the concentric fibrocartilaginous rings that wrap around the nucleus pulposus to contain it and help hold that kind of watery, gooey fiber in. There are a lot of bony articulations of the spine, and as a result, there are a lot of different types of joints that we are going to talk about here. We're going to reference their names, but we're not going to get too in-depth into specific identification because it's hard to palpate the difference in these specific joint locations at this level of things. So if we talk about our intervertebral joints, that's going to be between the bodies, and they are cartilaginous joints. So we're looking at the articulation between the vertebral bodies, not at any of the facet joint articulations where we see our inferior and superior aspects. Our facet joints have several different types of facet joints. So we have our intervertebral facet joints, which is the superior facet of the vertebra below and the inferior facet of the vertebra above articulating together. And that helps to influence the type of motion that can happen at that vertebral level. Then we have our costovertebral facets. So remember, costal is going to refer to the ribs and vertebral, the spine. So we're looking at the articulation of ribs and spine here. So costovertebral is the head of the rib with the vertebral body. Our costovertebral joints may involve 1 rib and 2 vertebral bodies because remember we have 3 costal facets, and where they meet with the vertebral body is an articulation with the vertebral body above and the vertebral body below. And then the costotransverse joint is the tubercle of the rib and the costal facet on the anterior tip of the transverse process. So that's going to cover our 3 costal facet joints. So we can just see here a little bit of the difference between our intervertebral joint, where we're looking at the bodies here. I know my highlighting is horrible. Cushioned by our intervertebral disc, versus our facet joint more posterior, where we're seeing the articulations within the spinous process. Or I'm going to correct that real quick, within the lamina, not the spinous process. So just looking at motion that's happening within those joints and how those joints are different from one another, our cervical, thoracic, and lumbar spine, our intervertebral joints are going to be our adjacent vertebral bodies. Those are cartilaginous joints because they have the intervertebral disc there. We see slight movement there, but it's primarily for where weight bearing happens through, because remember, weight bearing happens through the body of the vertebra. And then we have our facet joints, which is going to be the superior articular process of the vertebra below and the inferior articular process of the vertebra above. And those are synovial joints. So remember, they're going to have a joint capsule, they're going to have synovial fluid, they're going to have a synovial membrane, all of those things. Movement in the spine is due to the sum of motion at all joints, not movement at a single joint. So when we look at goniometry, we're not going to look at each vertebral level and how much it moves. We're going to look at the range of the trunk and its movement as a whole. Circling back to our special joints, so remember our atlanto-occipital joint is going to be between the occipital condyles and the superior articular facet of the atlas, and it is a synovial joint, and that's where we're going to see the yes motion be able to happen at the movement of the head. And then our atlantoaxial joint is going to be the articulation between C1 and C2, where we see the no movement of while the dens spins within C1. Also a synovial joint, so we've got synovial membrane, joint capsule, synovial fluid, all that stuff. These joints have the greatest amount of movement of any of the vertebral joints because of the way that they are made up. And this picture just shows where we had C1 and C2 separated before, and I talked about how the dens sticks up into there. So we could imagine that transverse ligament coming across like this here to hold that dens in place as those two sit the C1 on top of C2. All of these joints need passive structures to give them support and stability. So if we talk about some of the ligaments here, our anterior longitudinal ligament is going to run along the anterior aspect of the vertebral column, along the anterior aspect of the bodies of the vertebral column. The anterior longitudinal ligament serves to prevent excessive extension of the spine, because if that gets pulled taut, that would be the motion of extension. It's going to resist further motion in that direction. Comparing that with the posterior longitudinal ligament that runs on the posterior aspect of the vertebral bodies, if we pulled that taut, we would be preventing excessive flexion of the spine. We're going to talk about the other ones a little bit more in depth with some better pictures here. Looking at the more posterior ligaments here, we start at the most superior aspect where we have our nuchal ligament, and that runs from the nuchal line of the occiput to the spinous process of the cervical spine. And then at C7, it splits to form our supraspinal ligament, so above the spinous process, and our interspinal ligament between the spinous process. And so we can see there our supraspinal ligament runs from tip to tip of our spinous processes, where our interspinal ligament runs in between to run up towards the vertebral body. Muscles of the neck and trunk can be broken into three different categories based on where they're located. And so our anterior muscles are going to contribute to flexion of the neck and trunk. Our posterior muscles are going to contribute to extension primarily of the neck and trunk, though most of our muscles that contribute to rotation are going to be located posteriorly as well. And then lateral flexion of the trunk is going to be caused by motions that are located laterally in the spine and some of those posterior muscles as well. Jumping into anterior muscles of the neck, we're going to talk about the sternocleidomastoid first. I like this muscle because it's very nicely named. It tells me exactly where it attaches, right? Sterno, so it attaches to the sternum. Cleido is going to be for my clavicle, and mastoid for my mastoid process. So you can see here from the image my attachment on my sternum, my clavicle, and my mastoid process. My origins are my sternum and my clavicle. My insertion is my mastoid process, remember, because that's more distal to my trunk. The action of sternocleidomastoid, if they both work together, they're going to cause head and neck flexion. So if I have one on each side pulling my mastoid process down, I'm going to have flexion of the head and neck. Unilaterally, though, if those work one side at a time, I'll see lateral neck flexion to the same side, rotation to the opposite side. Sternocleidomastoid is also a muscle of our accessory muscle of respiration, but let's glaze past that for a second. I want you to put a finger on your sternoclavicular joint where we can kind of summarize or average the location of the origins of sternocleidomastoid, and one finger on your mastoid process. In order to bring those fingers together, you need lateral flexion in the same direction, and you can see how shortening of sternocleidomastoid would cause lateral flexion to the same side. But if I want to bring those fingers closer together for rotation, I have to rotate in the opposite direction. If I rotate in the same direction as the muscle, I see my fingers go farther apart. And so I can understand that the action is lateral flexion to the same side, rotation to the opposite side. This is really important to understand when we talk about stretching the muscles, because if we want to stretch sternocleidomastoid, we have to pull a patient into a little bit of cervical extension, but then we need to pull them into lateral flexion to the opposite side, rotation to the same side, to pull those fingers the farthest apart because that's going to pull the two ends of our muscle the farthest apart to provide the greatest amount of stretch. And our sternocleidomastoid is innervated by our accessory nerve and the third cervical nerve. Moving right along to our scalene muscles. Our scalenes are three different muscles that function as a unit. Our posterior scalene is our smallest and our deepest, with our anterior being our most superficial and middle is in between there. They originate on the sternum and clavicle to insert on the mastoid process, but because of their location and line of pull, they're more functional as lateral neck flexors than neck flexors, and so we see more lateral flexion than just straight plane flexion. You can compare this to their location and attachment to the sternum and clavicle with sternocleidomastoid and see how sternocleidomastoid has a more anterior line of pull that would cause just cervical flexion. When they act bilaterally, so both sides working together, we do get head and neck flexion, but they're not the primary contributors. Unilaterally, we see lateral neck flexion to the same side, rotation of the head to the opposite side. And that's going to follow the same rules that we talked about for sternocleidomastoid. If you palpate a finger on the origin and a finger on the insertion, making those fingers come closer together is going to indicate the action of the muscle. And it is also an accessory muscle of respiration. It is innervated by the accessory nerve and the second and third cervical nerves. This picture, take it, leave it, do whatever you want with it, just kind of shows you the relationship of the muscles of the neck. You can see our sternocleidomastoid and our scalenes anterior, our splenius capitis posterior, deep to our shoulder girdle muscles of upper trap and levator scapulae running there. This picture I leave in just to give everybody an opportunity to palpate the platysma. So the platysma lies superficial to your sternocleidomastoid, and it's the muscle that you would activate if you were trying to pull the bottom of your jaw out forward. So everybody try to activate your platysma because I'm going to ask you to do this in class and see who is successful with it. Our prevertebral muscles are before the vertebra, so this helps indicate that they are anteriorly located and that flexion is going to be a contributing factor to their action. We'll start with longus colli. So it has three parts. All three parts are neck flexors. The upper and lower parts are also lateral flexors. Longus capitis causes flexion bilaterally, lateral flexion with minimal rotation when activated unilaterally. Rectus capitis anterior flexes the atlanto-occipital joint when activated bilaterally. When activated unilaterally, we see rotation in the same direction. And then rectus capitis lateralis stabilizes the atlanto-occipital joint bilaterally and provides lateral flexion in the same side unilaterally. Looking at the anterior aspect of the cervical vertebra, we can see the location of all of those muscles. So rectus capitis lateralis is located more laterally compared to rectus capitis anterior, which is located more anteriorly. We can see our three parts of longus colli, with our middle part being located pretty midline at the anterior aspect, and helps us understand why it does not contribute to lateral flexion the same way the upper part and the lower part do. Sitting just below our occipital protuberance, we have our suboccipital muscles, so sub being below. Those muscles as a group act to create extension at the atlanto-occipital joint and rotation at the atlanto-axial joint. When we have bilateral contraction, we see stabilization of the atlanto-occipital and atlanto-axial joints. So if you look through the motions for each of those muscles, all of them have extension in common, and all of them have stabilization of one of those two joints in common. So we can see here, just based on their location in the line of pull, obliquus capitis superior, running from the transverse process of C1 up to the skull, is going to produce extension with some lateral flexion. Rectus capitis posterior minor, coming from the posterior aspect of C1 up to the skull, is going to produce extension. Rectus capitis posterior major, coming from the spinous process of C2 up to the skull, is going to help contribute to some rotation of C2, but also primarily extension. And then obliquus capitis inferior running from the spinous process of C2 to the transverse process of C1 is going to cause some rotation of that atlantoaxial joint, but again, primarily contribute to extension. All of them working together stabilize those two joints. Splenius capitis and splenius cervicis muscles are going to be posterior and deep to our erector spinae muscles. They are going to be named for what they contribute to motion for. So capitis is going to be capital for head, cervicis, cervical for cervical spine. So splenius capitis originates on the spinous processes of T3 to T6. Scratch that. Splenius cervicis originates on the spinous processes of T3 through T6 to insert on the transverse processes of C1 through C3. And we can tell that by its insertion, cervicis going to insert on the cervical spine. Bilaterally, they serve to cause neck extension. Unilaterally, they cause lateral flexion to the same side. And if you look at the picture there of splenius cervicis on the left side of that spinal column, you can see the line of Poole would cause a more lateral motion when activated unilaterally. They're innervated by the middle and lower cervical nerves. Splenius capitis originates on the lower half of the nuchal ligament and the spinous processes of C7 through T3 to insert on the lateral occipital bone and the mastoid process. It serves bilaterally to cause head and neck extension, because remember, it's attaching to the skull, so it's going to contribute to head movement. Unilaterally, it causes lateral flexion and rotation to the same side. And again, looking at that line of Poole, we see a little bit more oblique angle to contribute to rotation compared to splenius cervicis. External intercostal muscles. So these guys originate on the lower border of the rib above to insert on the upper border of the rib below. So they come from the bottom side of the top rib to stick on the top side of the bottom rib. They serve to elevate the ribs during inspiration, and if you look at the orientation of their fibers, it's like putting your hands in your pocket. So if you take your hands, put your right hand on the right side of your chest, the left hand on the left side of your chest, and point your fingers towards your belly button, that's the orientation of the fibers for your external intercostal muscles. And they're going to be innervated by the intercostal nerves from T2 through T6. Compare that to your internal intercostals. You take your hands from those same positions laid at your chest, pointed towards your belly button. Keep your hands in the exact same position, but move your right hand to the left side of your chest and the left hand to the right side of your chest, and see how they're like this inverted V that's formed. So our internal intercostals muscle fibers run in the opposite direction of our external intercostal fibers. They originate from the upper surface of the costal cartilage and the rib below to insert on the costal cartilage and costal group of the rib above. So they come from the top side of the bottom rib to go to the bottom side of the top rib to pull the ribs down during expiration. So externals help for inhalation, internals help for expiration. I know that that's oppositely named from what you want it to be, but just roll with it. They are again innervated by the intercostal nerves T2 through T6. And this is where we can see that V that those muscle fibers form. So the external intercostals running in that oblique direction, with then the internal intercostals running in that opposite oblique direction. Our external intercostals serve to pull the lower rib up to make the rib cage bigger for inhalation. Our internal intercostals pull the upper rib down to make the rib cage smaller for expiration. Rectus abdominis is the abdominal muscle that everybody seems to typically know, and nobody else knows any of the other abdominal muscles. It's a very superficial muscle, so it's the most superficial. It's the one that is visualized the most often. The right and left sides are separated by the linea alba. So the linea alba is the fascia that joins the right and left sides of the rectus abdominis muscle. And then our rectus abdominis is further divided by tendinous intersections, and that's what give us the quote-unquote six-pack look. The origin of rectus abdominis is going to be the pubic crest, so we come down from the pelvic bone to insert on the xiphoid process and costal cartilages of the 5th through 7th ribs. So the muscle is originating down more inferior to insert more superior, because the pelvis is more centrally located location of, or for anatomical position. We're looking for the action of trunk flexion because it's an anteriorly located muscle, and it also contributes to compression of the abdomen to maintain appropriate intra-abdominal pressure. When the pelvis is stabilized or fixed and we have activation of rectus abdominis, we can have depression of the ribs, which can help it be an accessory muscle of respiration. It is innervated by the 7th through 12th thoracic nerves. So because of its line of pull, rectus abdominis is a really important muscle in contributing to the force couple that helps to produce posterior pelvic tilt, or rotation of the pelvis in the posterior direction. So if you remember from chapter 2, a force couple is produced when we have forces going in opposite or opposing directions around a central axis to produce rotation. So with the stabilization of our pelvis at the SI joint, if this is our anterior side and this is our posterior side, ignore my bad writing. If I have activation of the rectus abdominis from that pubic tubercle pulling up, and I have activation of my hamstrings from my ischial tuberosities pulling down, the result is a rotation of my pelvis that gives me posterior pelvic tilt. We'll talk about anterior and posterior pelvic tilt more in the chapter on the pelvis, but it's important to understand rectus abdominis' role in creating and maintaining a posterior pelvic tilt and why it can be important in targeting postural deformities or abnormalities. Our external oblique is going to have its fibers oriented the same way that our external intercostals did. So that's going to be oriented like putting your hands in your pockets and how your fingers point in that direction. They're going to originate from the lateral surface of the lower 8 ribs to insert on the iliac crest, pubic tubercle, and linea alba via the abdominal aponeurosis. When activated bilaterally, they cause trunk flexion because they are an anterior muscle, and they can also contribute to compression of the abdomen for maintenance of appropriate intra-abdominal pressure. But when used unilaterally, we get trunk lateral flexion and rotation to the opposite side. So it's important to associate external obliques with opposite rotation. When the pelvis is stabilized, it can serve to pull down on the ribs and depress them, acting as an accessory muscle of respiration. It's innervated by the 8th through 12th intercostal nerves, the iliohypogastric nerve, and the ilioinguinal nerve. Our internal obliques orient in the same direction as our internal intercostals, so that our internal obliques cause that same V with our external obliques that our internal and external intercostals caused. They originate on the inguinal ligament, the iliac crest, and the thoracolumbar fascia to insert on the 8th through 12th ribs, linea alba via the abdominal aponeurosis. When acting bilaterally, they're anterior muscles, so they cause trunk flexion and also contribute to compression of the abdomen for maintenance of the appropriate intra-abdominal pressure. Unilaterally, they cause lateral trunk flexion because of their more lateral location, but rotation to the same side because of the orientation of the fibers. So our internal obliques, we have to get rotation to the same side. External obliques, rotation to the opposite side. When the pelvis is stabilized for our internal obliques, they can also help to depress the ribs, making them serve as an accessory muscle of respiration. They're innervated by the 8th through 12th intercostal, iliohypogastric, and ilioinguinal nerves. Transverse abdominis. This is my favorite muscle of the spine. It is the most overlooked, underutilized abdominal muscle. It is so important for spinal stabilization, but it gets shut down by our bigger muscles, rectus abdominis, and our internal and external obliques, that a lot of people don't have great activation of their transverse abdominis, and that's why they have back pain. Transverse abdominis runs deep to our internal oblique, so it's a very deep muscle, and it also runs horizontally, so it doesn't contribute to trunk motion. It doesn't help with trunk flexion, even though it's an anterior muscle, because its fiber line of pull is horizontal. It's not going to pull our sides closer together, but it creates tension within our abdomen that helps to stabilize our spine in a very important way. It originates on the inguinal ligament, the iliac crest, and the thoracolumbar fascia, and the costal cartilages of the lower 7 ribs, to insert on the pubic crest and linea alba via the abdominal aponeurosis. It acts for compression of the abdomen and stabilization of the spine, and it is also an accessory muscle of respiration, innervated by the 7th through 12th intercostal, iliohypogastric, and ilioinguinal nerves. The horizontal line of pull means it does not contribute to trunk movement, but it is important for spinal stabilization. Activation of transverse abdominis does not require trunk movement. We can do that by having patients do abdominal draw-ins. We can see here our external obliques as our most superficial. Then we've got rectus abdominis just deep to the aponeurosis there, and then we have our internal obliques running underneath of that, and then transverse abdominis is deep to all of them. We talked about how our external obliques and our internal obliques have fibers that orient in opposite directions to create that V on the same side of the body. But when we look at it on the opposite side of the body, our external obliques of our right side are oriented in the same direction of the fibers of our internal obliques of our left side. And so that means that we have muscles on both sides of the body working together to create rotation when we have trunk rotation. So if I'm trying to rotate towards my left, my right external obliques cause opposite side rotation, so I would need my right external obliques, but my left internal obliques cause same side rotation. So if I want to turn towards my left, I would need left internal oblique activation and right external oblique activation to get that rotation to occur. Quadratus lumborum is our lateral trunk muscle, so it's going to help us with lateral trunk flexion. Tightness in the QL can contribute to gait deviations in which a patient have a leg length discrepancy. I want you guys to think about why that would be a case based on its origin and insertion and how we would get a leg length discrepancy if we had tightness in the QL. Our quadratus lumborum originates from our iliac crest to insert on the 12th rib transverse processes of all 5 lumbar vertebrae. It serves for trunk lateral flexion to the same side. We can't get activation of both unless we are trying to stabilize the trunk. Bilateral activation of our quadratus lumborum would have them fighting against each other because they're oppositely placed. When the ribs are stabilized, it can cause pelvic elevation. So if I have my leg planted, it's pulling down on my ribs and helping cause lateral flexion. But if I have my leg free, I can get pelvic elevation with activation of my quadratus lumborum. And QL is innervated by the 12th thoracic and 1st lumbar nerves. Our posterior trunk muscles run a couple levels at a time and serve to cause a whole bunch of different motions based on their line of pull. Individually, the muscles only span a few segments, so trunk motion is produced by a collection of muscle activation. So if we look at the muscles that contribute to extension, we're looking at the spinalis group of our erector spinae and our interspinalis muscles. Extension and lateral flexion are going to be caused by the longissimus group of our erector spinae and our intertransversari. Extension and rotation to the same side will be caused by splenius cervicis. Extension with rotation to the opposite side is going to be caused by our semispinalis, multifidus, and rotators muscles, all through our transverse, and all from our transverse spinalis group. And then extension and lateral flexion will be produced by our iliocostalis muscles, or iliocostalis group of our erector spinae muscles. So these combination of movements, all of them contain extension because they're located on the posterior side, but the combination with either lateral flexion or rotation to the same side, rotation to the opposite side, whatever the case may be, is all based on that muscle's line of pull. So muscles attaching from spinous process to spinous process are going to produce extension because they have a straight plane line of pull for extension. Muscles that attach from transverse process to transverse process are going to produce lateral flexion unilaterally and extension bilaterally because they are more laterally located. When they activate unilaterally, they're going to pull those two segments closer together on the side, causing lateral flexion. If we look at C here, so we're looking at the transverse attachment is superior with the spinous process attachment inferior. So if we see that, rotation is going to be towards the same side because the superior segment is the one that's moving. So if I start inferiorly on a spinous process and I move superiorly to a transverse process and I pulled a rubber band, that transverse process is going to pull towards my spinous process, causing rotation to the same side. But if my transverse process is my inferior attachment and my spinous process is my superior attachment, like we see in D, Then I'm going to have rotation towards the opposite side because, again, my superior segment is the one that's moving. So if I pull on that spinous process towards my transverse process, I'm going to see rotation to the opposite direction. Please let me know if this is confusing to you, and we will look at it with some models in class, but this is an important concept to understand. Our erector spinae muscles run the length of our spinal column on the posterior aspect, and we've got three groups of them that are then named according to the region of the spine that they're in. Our spinalis group is going to be the most medially located group. Then moving laterally from there, we'll have our longissimus group, and then most lateral of the erector spinae muscles is going to be our iliocostalis muscles. Bilaterally, our erector spinae muscles cause extension of the spine. Unilaterally, they produce lateral flexion and rotation to the same side throughout the spine because of the way that they are oriented. So that means that our attachment to our spinous process is always going to be inferior compared to our attachment to our transverse process in order to achieve rotation to the same side. So we can see our erector spinae muscles on the left-hand side of this picture that we just talked about. On the right-hand side, we have our transversospinalis group. So we have our semispinalis muscles, our multifidi, and our rotators, all as a part of our transversospinalis group. And then we also have our inner transversari group of muscles that are running in between the transverse processes down here. And you can see they run throughout the spine, but you see on the lateral aspect transverse process to transverse process. Taking a little bit closer look at our transversospinalis muscle group, they're all located in grooves between the transverse and spinous processes and all have an oblique line of pull. Our semispinalis spans typically 5+ vertebrae and is part of our erector spinae group, but we have a little bit less span when we're looking at our transverse spinalis group because if you look at our rotators, typically only span 1 vertebra. Our multifidi span 2 vertebrae. Transversospinalis means that they all run from a transverse process to a spinous process, and so they're typically going to cause rotation to the opposite side. Transversospinalis muscle group originates on a transverse process below to run to a spinous process above. Remember that the superior segment is the part that moves, and so when unilaterally activated, they're going to cause rotation to the opposite side. They'll also contribute to lateral flexion unilaterally. Bilaterally, they cause extension, and all of these are innervated by the thoracic spinal nerves. Our interspinalis muscles, so inter between spinous processes, are going to originate from the spinous process of the vertebra below to insert on the spinous process of the vertebra above. They are going to cause neck and trunk extension because they are centrally located. They do not contribute to lateral flexion or rotation. All are innervated by the spinal nerves at their corresponding level. Our intertransversary muscles, so inter between transverse processes, are going to run between our transverse processes of our vertebral column. They originate on the transverse process of the vertebra below to insert on the transverse process of the vertebra above. They serve to cause neck and trunk lateral flexion to the same side. They do not act bilaterally because their actions directly oppose each side. And they are all innervated by the spinal nerves from the corresponding level. Our diaphragm is a big sheet-like dome-shaped muscle that is extremely important for respiration and changing the volume of the chest cavity to draw air in. It originates on the xiphoid process, the ribs, and the lumbar vertebra, and inserts via a central tendon, so it doesn't have a bony attachment at its insertion. Its action is to cause inspiration. It is innervated by the phrenic nerve, specifically levels C3, C4, C5. You can remember that for the mnemonic C3, C4, C5 to stay alive, because we need to have our diaphragm innervated in order to be able to breathe. This will also carry over when we talk about spinal cord injury patients and level of injury for ability to perform self-respiration or needing mechanical ventilation. Common pathologies of the neck and trunk we'll talk about here. So torticollis is going to be a pathology that's most commonly seen in the pediatric populations, though it can progress into adulthood. And I have seen patients, especially patients with Parkinson's, who have become frozen in some of these more sustained postures, develop torticollis, but it is primarily present in our pediatric population. It can be congenital or acquired, meaning that you were born with it as a result of shortening of the muscles during development as an embryo, or it can be acquired typically through long-term positioning. When seen in the pediatric population, we typically have to educate parents on stretching, but also changing the child's direction of preference and not setting them up in front of the screen the same way or the same direction all the time, or setting them up to feed the same direction all the time. We have to orient them or educate them to change their orientation so that they're encouraged to turn their head in multiple directions. If they have multiple heads, then we have bigger problems. What we will see in a patient with torticollis is that their head is laterally flexed to one side and rotated to the opposite side because it's caused by shortening of the sternocleidomastoid muscle. And so if you'll remember putting your fingers on your sternum and putting your fingers on your mastoid process and bringing those closer together, that would be the position that the head would be stuck in as a result of that shortened sternocleidomastoid. Sciatica is a colloquial term that is used to describe pain in the distribution of the sciatic nerve. It's most commonly caused by disruption of the disc or a herniated disc, but it can also be caused by piriformis syndrome, where the sciatic nerve passes through the two heads of the piriformis and get compressed when the piriformis is tight. And this results in pain descending the posterior thigh and leg along the path of the sciatic nerve. Typically, it'll go down to the knee, but then as it worsens, can extend down the posterior calf into the foot as well. Postural abnormalities can be other pathologies that we see in the neck and trunk. So changes in normal spine curves. We talked about how we should see a lordotic curve in our cervical spine and our lumbar spine, and a kyphotic curve in our thoracic spine and our sacral spine. But abnormalities of those curves can cause lordosis or kyphosis as appropriate. Lordosis can be the normal curve, but when we see an increase in anterior convexity, that's when we push it into the pathological lordosis. Kyphosis, on the other hand, is typically not described as normal. We say that we have a kyphotic curve of the thoracic spine, but kyphosis is typically described as the pathological condition of an increased posterior convexity. And so that's going to be that rounded shoulders, forward hunched posture that we see a lot of our elderly population develop into. Scoliosis is going to be a lateral curvature, so that's where we see that S shape of the spine instead of in that sagittal plane, the frontal plane. We're seeing the S shape because it's that curve to one side or the other. Screening for scoliosis should be done between the ages of 9 and 11 because this is when we can do the most to influence with growth and appropriate bracing to correct the curve. And then flat back is going to be a decrease in normal curvature, so a decreased lordosis. We're specifically talking about the lumbar spine when we talk about flat back and postural abnormalities. So we see a decreased lordotic curve and a flattening of the lower back. Spinal stenosis is where we see narrowing of the vertebral canal and causes compression of the spinal cord or the spinal nerve roots that's worsened with spinal extension. There's pain and loss of motor and sensory function depending on where the compression is happening. So if it's happening to the spinal cord, we tend to see it below the level of the lesion. If it's happening to the spinal nerve root, we tend to see that in more of a dermatomal and myotomal pattern. Patients demonstrate a preference for lumbar flexion movements because lumbar extension worsens the symptoms of spinal stenosis in most cases. Ankylosing spondylitis is caused by chronic inflammation where we see fusion of the vertebral column joints and can be commonly referred to as bamboo spine. These patients typically benefit from movement and maintaining movement as much as possible in the least weight-bearing positions, so they benefit a lot from being in a pool where we can make them less weight-bearing to allow for trunk and neck movements. Spondylosis is going to be a problem at the articular surface, and so we think of spondylosis like arthritis. This is our bony spurs, the thickening of ligaments, and decreased disc height, and there can be pressure on the spinal nerve roots as a result of all of these changes that are happening. And if we have compression or pressure on the spinal nerve roots, then we present with radicular symptoms, which is symptoms that are going to run in our dermatomal myotomal pattern. Spondylosis is going to be a defect in the lamina of the vertebra. So remember, the lamina is what runs from the vertebral body out towards the transverse process. And when we see a defect in that, that can be like a fracturing or degradation. but spondylosis is developing, and this can put the patient at risk for developing spondylolisthesis, which then is the slippage of one vertebral body anterior on the vertebra below. So if we have disruption of the lamina where the vertebra or the vertebral body can then move because of a development of spondylolysis, that patient is at risk of progressing to spondylolisthesis. We need to prevent positions of extension, spinal extension for these patients because we don't want to push that vertebral body any farther anterior. These patients will need to have exercises in a flexion-based bias. And fractures that we can see through the neck and trunk. So we can see compression fractures where we have a collapse of the body of the vertebra, and basically it just starts to fracture under the weight of whatever is above that body. This can be caused by trauma, but it is more commonly caused by osteoporosis. We can see fractures with dislocation that commonly happen most commonly as a result of trauma, and this can result in compression of the spinal cord or avulsion of nerve roots and loss of motor and sensory function dependent upon where the nerve root involvement is. And cervical strains, more commonly known as whiplash, are strain of the muscles and ligaments supporting the vertebral column. Most commonly impacted is going to be obviously the cervical spine because we have the most mobility at the cervical spine and the least stabilizing factors. I do not believe I put in an extra slide here to remind you to review this before class. Come to class prepared with both your goniometer and your tape measure for neck and trunk because we will need your tape measure for trunk motions. Please make sure that you prepare any questions that you may need to help clarify any content in this lecture and come appropriately clothed for lab.